Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today in the show, we have Hilary Bowers. She's a pediatrician. Her Kevin MD article is titled Changing the Pediatric Care Landscape, Integrating Behavioral and Mental Health Care. Hilary, welcome to the show.
Thank you so much for having me on. I really appreciate it.
So we'll get into your article in a little bit. First off, briefly share your story and journey to where you are today.
Yeah. So I am a general pediatrician by training. I have lived all over the country, grew up in the Midwest, East Coast, West Coast, and currently I am based down in San Diego, California with Children's Primary Care Medical Group. And I'm currently the Director of Behavioral and Mental Health Services for our organization. We're the second largest single specialty pediatric group in the country. So quite a few patient lives that we're touching, which I really appreciate.
So tell us some of the challenges and rewards of practicing pediatrics in today's healthcare landscape.
So we have, obviously there's reimbursement issues, there's time issues. We've had a pandemic. I think maybe you've been living through that as well. Issues. But I think one of the biggest things in pediatrics is that when you walk into the room as a pediatrician, you don't have just one client, right? You have your patient, but then you also have the parent, the caregiver, the aunts, the siblings, whoever else is also in the room with that patient, whoever else lives at home with that patient is part of your care team, and trying to convince not only a 5-year-old of what you would like them to do, but also the parent of the 5-year-old, because obviously the 5-year-old's not driving to the store to do the grocery shopping.
So you mentioned the pandemic, and of course there's that intersection between the pandemic, pediatrics, and behavioral health. Tell us what you're seeing in the exam room today as it relates to that.
So currently we're seeing a significant increase in behavioral mental health concerns. I think one of the biggest shifts that we've seen with the pandemic is that these concerns were always there. Even pre-pandemic, 1 in 5 children would be diagnosed with some behavioral mental health diagnosis by the age of 18. What we've seen since the pandemic is that a third of our adolescent girls are depressed. 1 in 7 males are contemplating suicide. Males in general tend not to talk about it. So that whole thing as a pediatrician, how do you create that relationship with your patient so they trust you? They're willing to confide in you. They're willing to recognize that they are having challenges and that you are a source of support for them, which I think is so very important. Out of the ACEs studies and looking at childhood traumas, also looking at the resiliency factors. One of the major resiliency factors is having one trusted adult in your life. And by having that, it's somebody who sees you, somebody who is showing up for you, expects you to do amazing things in your life, that then, regardless of what you may be experiencing at home or at school or personally, allows you to go ahead and move forward and achieve those goals. So you as the pediatrician can be that trusted adult.
All right, you talk more about that in your Kevin MD article, Changing the Pediatric Care Landscape, Integrating Behavioral and Mental Health Care. Tell us, how did this article come together?
So I'm going to take you in the time machine, and we're going to go back to 2015 when I had one of those aha moments with a patient who literally sat down and pointed a finger at me and said, "Why can't you take care of my patient? Why can't you take care of my child?" They had to go see a psychiatrist to get their medication. They were talking about how I have very many psychiatry colleagues who I love, but their particular experience was that it wasn't a satisfying, relationship base that we think about in pediatrics. And I said, well, why not? So I presented to our leadership at that time and said, we need to bring behavioral mental health back into the primary care home. How can we harness our pediatricians' knowledge and really deploy it across our organization? Fast forward. We're now many years later, we have educated across our organization in what I consider the big 3, ADHD, anxiety, and depression. How do we diagnose it? How do we treat it? How do we talk to families about it? And then also we have, some of our offices do have integrated health therapists located so that way we can have more immediate access to that therapeutic service that we know is so important. Medication is just one of the tools in our toolkit. And we know for sure that having that therapeutic, doing that behavioral modification is key. So the Kevin MD article comes out of my desire to make sure that everybody has access to this knowledge. This is something that we did in our organization, but smaller groups can do this as well. And how do we pivot and make sure that we're providing the care that our patients need at the correct time?
So give us a before and after picture. So before this intervention, what would it be like for a child and their family with one of the big three, ADHD, anxiety, depression, coming to your office, and then after the intervention? Give us a before and after picture.
So before, a family would call in and say, I think my child is struggling with inattention or depressed mood. And sometimes our pediatricians wouldn't even bring them in to have a conversation. They would just say, okay, you need to go see a psychiatrist or go find a therapist. Or if they did bring him in, sometimes it would be a kid who was missing a lot of school or chronic headaches or belly pain, and the child would wind up being sent to GI for a workup. And now a kid's having tests and scopes and things. And in the end, it may have turned out that it was the anxiety talking and bringing on these physical symptoms, but it would have been a very expensive, very costly and timely workup. That was the before. Now what we have is our pediatricians who are willing to have the conversation with the families. They come in just like if you have someone coming in and saying, I'm concerned, my kid may have a broken leg, or my kid may have an ear infection or diabetes. I'm concerned my kid has attention concerns. Same thing, just like we learned back in medical school, the history and physical rules everything.
Mm-hmm.
So have the family come in, you sit down, you have a conversation with them, and then you're able to make a much more informed decision as what the care plan needs to be. I will say, Kevin, one of the things I've noticed in this area of medicine is that there is so much forgiveness from the families. It's really one of the only times where I've had maybe a 30 or 60-minute conversation with a family. At the end of the conversation, the entire plan is I'm going to go call my psychiatry colleagues. I'm going to call my therapy colleagues. We're going to come up with a plan. I'm going to call you back in a week. So, and the families are ecstatic.
Mm-hmm.
They are so happy that somebody took the time to listen and that you're going to join them on the journey to wellness for their child. So it's really quite rewarding.
So tell us about the education itself. What kind of training did you implement among your clinical staff?
So we actually partnered with the REACH Institute, which is a nonprofit organization. And it starts with we did the PPP training. So it's psychopharmacology. I always mess up the title.
Sure.
It's a PPP training through the REACH Institute. So it's a 3-day workshop. Friday, Saturday, Sunday. So you're not missing a lot of time. And they actually do quite a bit of it online. They shifted online due to the pandemic. Friday, Saturday, Sunday, education on ADHD, anxiety, depression, as well as a little bit on bipolar disorder, atypical antipsychotics, and things like that. There's role play involved with that. There's small groups. It is led by master child and adolescent psychiatrists and master pediatricians. And that is followed by 6 months of every other week, 1-hour case-based presentation. So one of the pediatricians in the group, again, this is proctored by a child and adolescent psychiatrist and a pediatrician from the REACH Institute. You do that 5-10 minute presentation, and then you have the rest of the hour to discuss and come up with a plan of care. What else came up? How do I then take that to my other patients in clinic? So it really solidifies the knowledge. We've had, as you may imagine, some physicians really lean into this kind of work and some do not. And we definitely have some people that did not. And they were, I'm doing this because I have to, not necessarily because I want to. So that was Friday. Monday, they emailed us and said, that was the best CME I ever had. And Monday, they felt that they had the tools to be able to at least have the conversation with the families, to be a little more in that slightly less uncomfortable position of feeling like you had that knowledge. I think one of the other key things that we've been doing for education purposes is to say, this is a little different than some areas of medicine, right? A kid comes in with an ear infection, they give them an antibiotic, they get better in 48 hours, they're moving on with their day, right? So there's a challenge, there's a cure. Here, there's a challenge, but the road to wellness may take a little bit longer. And teaching all of our clinicians, because we have pediatricians, we have NPs, we have PAs in our organization, teaching them all to be a little more comfortable in the unknown. And that is a challenge, right? That's a challenge for us as practitioners to be able to say, I'm going to take the journey with you. I don't know exactly how long it's going to take.
So tell us, in terms of general pediatric training, without having this CME from the REACH Institute, what kind of training do most pediatricians have when it comes to some of these behavioral health issues?
So most pediatricians have a month of developmental behavioral pediatrics. Yeah. And that's kind of vary depending upon what organization you're at. And if you've been in practice for a few decades, you may not have even had that training. There are some places that maybe you do 2 weeks with child and adolescent psychiatry, but it's just not. Most of pediatric training is still very hospital based, right? There's lots of time in the NICU, there's lots of time in the ICU on the wards, and not as much time out in general community pediatrics.
So if you wanted to spread this program to other pediatric programs, other pediatricians across the country, tell us what will be the next steps.
I think one of the key things is identifying a champion within your organization. Somebody says, I will take the lead. I'm going to do a little research. I'm going to be the one, maybe serve as an internal referral for our organization. So that's what I did at the beginning, was I was serving as an internal referral. My general pediatrician colleagues would refer a patient to me, and then they could get in a lot faster than our community. So having a champion is key. Ongoing education, making sure that everybody has the same knowledge base, the same language, because we've all gone through this training together. We all have a common language we can speak now, and it's not just medicalese. And then the ongoing education piece is key. So not just that 6-month follow-up, but we have ongoing talks every other week, very short, case-based, on Zoom, so nobody's driving, which is key. And having that so that it's continuing to be at the forefront of our mind as pediatricians, that yes, we can have these conversations. Yes, oh, right, I was doing that. Yep, still the right thing to do. So I think that's really important to have that ongoing education piece. Another thing that we're doing is, myself and the Associate Director of Behavioral Mental Health Services, we're doing road shows. So we are going out to the individual offices. We have a questionnaire that several questions that we ask before we go and identify sticking points as to maybe why they're having challenges, and then coming with very concrete way to say, okay, let's do these 2 new things. Let's see how it goes. We'll check back in with you. So like where any other organization, where you're trying to make a change, you make a little bit, you check back in, you do it again.
We're talking to Hilary Bowers. She's a pediatrician. Her Kevin MD article is titled Changing the Pediatric Care Landscape, Integrating Behavioral and Mental Health Care. Hilary, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
I think the key is you can do it, right? I think a lot of people are afraid of change. And remember, our patients are afraid of change as well. We are all human, but you can do it. Start with one patient. Say, here's a patient of mine that I've known for years. I see that they're struggling. I'm going to attempt. I'm going to give them the PHQ for depression, or the Scared for anxiety, or the Vanderbilt for the ADHD. We're going to try it. Identify support either within your organization or within the community. Develop a relationship with some child and adolescent psychiatrists. I have found that they are amazingly receptive to, they are also overwhelmed. So if you can work together as a team, that's great. So take that initial step, maintain your personal support network, and go out and try honest, open communication with your organization and also with your patients will get you very far.
Hilary, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you so much for having me. I really appreciate it. Take care.